Good evening, everyone present here. Good evening, everyone present here. I am Faraz. I welcome all the esteemed doctors and medical professionals on a very warm welcome on today's CME on a very important topic supported by Lily. And today's discussion mainly rapidly involving the medicine obesity. So, can we have the topic for today's? Yes, today's discussion is based on obesity moving beyond willpower, recognizing it is a chronic disease. As we know that this is a critical topic because we understand that obesity is fundamentally a complex neurohormonal metabolic disease, not a simple lifestyle choice. Truly help our patient, we must adopt chronic disease management strategies. And all this requires expert guidance, both on medical and surgical fronts. To make this complex and important topic more simple, actionable, and truly knowledgeable for your daily practice, we have our two expert speakers to present on this topic and from two different specialty. So we are very fortunate and glad to invite our first speaker, and like he don't need any introduction. He's none other than Professor Dr. Rakesh Sahay sir. And let me share some of the achievement of sir. Sir is a professor of endocrinology at Osmania Medical College since 2009, and he was president of South Asian Federation of Endocrine Society 2023-2025, Diabetes Pregnancy Study Group of India DIPSI 2024, Research Society of Study of Diabetes in India 2024, and ESI 2021-2022, and section editor Tropical Endocrinology Endotext online textbook of endocrinology, and associate editor of IJDDC editorial board, member of IJEF, and governing body of Association of Physicians of India 2010-16, and he have several achievements. So we will share some of the achievement of sir. Sir is best teacher in medicine award from government of Telangana 2018 on Teachers' Day, and Holset Senior Lectureship Oration of Association of Physicians of India for 2008, and over 200 publication in various national and international journals with 7,500 sciatons and H index of 43, and authored chapters in various textbooks, monograms, and diabetes endocrinology. So moving forward for our another speaker, she also don't need any introduction. She is very good and expertise on his field. And we would like to welcome our next speaker, Dr. Nanda Rajneesh ma'am. And let me share some of the achievement of ma'am. Dr. Nanda Rajneesh ma'am is a renowned breast cancer and bariatric surgeon with over 20 years of surgical experience. She is widely respected for her patient-focused approach, combining compassion with advanced surgical skill. At Sakra World Hospital, Bengaluru, she served as a consultant in the Department of Breast and Obesity Surgery. And let me share some of the achievement of ma'am too. Over 2 decades of experience in oncology and bariatric surgery, pioneered the breast conservation surgery and sentinel lymph node biopsy, and recognized for her work in women's health advocacy and breast cancer awareness, and founder member of team at Nova that pioneers the concept of short stay surgeries. And she has published many papers, authors of 3 books, Life with Fibromyalgia, which is based on her own story, and Risk Factor in Breast Cancer, basically tips in preventing reoccurrence too. This third book is Are You Vegetarian Allergic to Food? Editor of Book Cancer Prevention Guide. So without any further delay, I welcome both the speaker with great honor for today's talk show. So moving forward, we will start with Dr. None other than Professor Rakesh Sahay sir. Sir, over to you, sir. You can start with the presentation of
Yeah,
yours.
thank you. Can you see my presentation? Can you see my presentation?
Yes, sir. We can
Thank you.
see your presentation, but sir,
Thank,
you are not visible, sir. Like your camera is showing black. Can you please turn it down?
okay. I need to stop sharing and share again.
Hide, sir. Hide it, sir. Hide it. No need to
Hide.
stop share, sir.
Okay.
You can click
Okay.
on hide
Hide.
and go to your browser.
Okay, okay, okay. So
Yes,
you
sir.
can see me now. But my
Now you can
presentation,
turn again. Sir, it is showing black, sir. Like,
I go back to my presentation. Yeah.
sir, your presentation is visible, but your camera is showing black, sir. Like you are not visible.
Oh, oh, oh. No, I put on, but I think there's some
Yes, sir. You
issue.
can try to minimize, sir. Minimize the screen, sir, and you turn off and turn on your camera. Browser, sir. Google Chrome.
I go back to my browser, yeah?
Yes, sir. And you try to switch off and on your camera, sir. There is some technical issue. Try to switch off your camera from below, sir. Below, not from the screen, from the down.
Acha,
Go
from the
below, sir. Yes, yes, sir. And try to.
switch it back on. Yeah, I've switched it back on. I can see myself on the screen. I can see my camera working here.
Sir, we can't see. So at initial it was showing, but right now we can't see you.
Mhm. Now is it seen?
So presentation is seen, sir. You can carry on, sir. You can start,
I'll
sir.
carry on. I'll
We'll
carry. I'll
just
carry on. I'll carry on.
yes, sir.
So, thank you for the kind words of introduction, and thank you for inviting me to this interesting webinar where we are discussing the basis of obesity, and we are trying to understand the various causes for obesity, consequences, and how to control this problem. Because why we are discussing this is because this is a global problem which is recognized not only by healthcare professionals, but if you look at the lay press, we saw that there are several articles which are speaking about obesity, how the problem of obesity is growing worldwide. This is a lay press article in published in March 2024, which said that there are 2.5 billion people who are overweight and obese worldwide, and 890 million people who are obese across the globe, and also the fact that children are also being affected by the problem. So this is a problem which is recognized globally, and it's seen that this problem is increasing worldwide, and we need to understand what are the issues which are leading to this problem, and how do we overcome this, and what are the consequences of this burden of obesity that we are speaking about. So we are seeing that over the years the prevalence of obesity is increasing, and it's not only amongst men or women. Both men and women are affected equally with this problem, and then also the fact that children also being affected, and that is the reason why we are seeing that obesity leads to several metabolic disturbances, and as is evidenced from this data from the ICMR INDAB study, which was published in 2023, and which gave us a very good snapshot of what is happening across the country. Across the country, we are seeing this was done across all the states in the country, and it shows that the prevalence of diabetes is quite high. But even greater than all that is the driver of this epidemic of diabetes, which is obesity. Obesity is there are 254 million people with obesity in our country itself. And if you look at abdominal obesity, because what we see is that while most of our people are not very much obese, there is a bigger problem of abdominal obesity. The obesity which is caused because of fat deposition in the abdominal cavity, and which we call it the as abdominal obesity, that is recognized by measuring the waist circumference, and that is even bigger problem. And we are seeing that all the consequences that happen because of obesity, that is dyslipidemia or the hypertension, cardiovascular disease, all these are a significant problem in our country. So basically, to understand what determines the body weight, we know that it's in simple terms you can say it's the balance between the energy intake and the energy expenditure that decides how much the body weight is. And if you look at the energy intake, that is again regulated by the hunger, the satiety, and the amount of nutrient absorption that is happening. While if you look at the expenditure, energy expenditure, there are different categories of energy expenditure. We have a basal energy expenditure that's happening, that is decided by the metabolic rate of the individual. Then there is something called as thermogenesis, which is happening, which again is a constitutive activity which is going on. And in addition to that, there are the exercise that we do, the amount of physical activity that we indulge in, that decides that again is a component of the energy expenditure. And additionally, one more component is the non-exercise activity thermogenesis. So that is the people who are moving around, in apart from doing the exercise, those who are a little fidgety and moving around, they tend to have a higher need as compared to those who are who are not that moving around in between their exercise and in between their purposive physical activity. The other aspect is the need. So these are all the components of the energy intake and energy expenditure. We have understood these, and these are all deciding what is happening in terms of the body weight. So they regulate the body weight. Now the brain plays a very important role in controlling appetite. There are different centers in the brain which are particularly hypothalamic centers, which are controlling the appetite. They are centers for satiety, and they are centers which are increasing giving a signal for increasing for eating, while the centers that are suppressing the appetite, they are giving a satiety feeling. And then in addition to that, all this is controlled by the executive function, which decides whether we should eat or not. And and then there are these thoughts and feelings which are controlling the food intake. So this is how, apart from the various neuropeptides and other peptides which are gut related peptides, which are regulating the appetite, which are influencing the satiety center, and which are regulating the center for increasing appetite. There are other aspects which are reducing which are controlling this, and that is the hedonic inputs that are decided by the appearance of the food, the how the so this is how appetite is normally regulated by complex interplay of different signals and areas in the brain. Increased understanding of the biology of appetite regulation has led to development of new generation of pharmacotherapy. Several newer therapeutic compounds have come into the market, and I'll be briefly discussing about those also in the subsequent phase. So now when you look at obesity, uh, while there are certain secondary causes of obesity, like certain medications, like the antipsychotics and several steroids and some other medications can cause weight gain. These are not a very important component of, if you look at generalized obesity. It's more because of the sedentary lifestyle, poor sleep, stress and emotional eating, and the use of and change in our food habits in terms of using of more of highly processed calorie dense food. So these are the three major factors, or which are contributing to obesity. While hormonal imbalances, which are contributing to secondary cause of obesity, are contributing only to a small percentage. Similarly, genetic causes of obesity are also contributing to a very small percentage of obesity. If you look at endocrine disturbances which can have obesity, which are linked to obesity: hypothyroidism, hyperinsulinism, hypercortisolism, and growth hormone excess or growth hormone deficiency also, they contribute to less than 5% of all obesity. It's more of the environmental influences and the and our lifestyle, which is contributing towards the growing prevalence of obesity. Now, we look at the genetic factor. Although there are several different genes which regulate obesity, which regulate the appetite, and which are you could say they are the obesity traits, and they are regulating the BMI through regulating the appetite and regulating the energy expenditure. But you could say that this contributes only to a small percentage of the people who have a monogenic obesity, that doesn't actually make a significant number when you look at that. So monogenic obesity versus common environmentally influenced polygenic obesity, if you look at these two, you can see that monogenic obesity has an early onset with high genetic distribution contribution. Single mutation in one gene can be identified, and there's a high penetrance. There are not much of environmental influences which are contributing to that, When you look at the common garden variety obesity, we are seeing there is more of a environmental influence. This is the key determinant, and although genetic factors may have a small role to play, but they are not the ones which are playing a major role in this form of obesity. Now, obesity. What are the problems associated with obesity? Is it? I mean, although we would think that person who is gaining weight is probably doing very well, but it is associated with significant problems. And these problems, if we want to categorize them, we could categorize them into two categories, three categories. We could say metabolic complications like development of type 2 diabetes, development of cardiovascular disease or strokes or lipid abnormalities, hypertension, and even heart failure, with initially preserved ejection fraction, which can later go on to a reduced ejection fraction. Then the other important aspect is the metabolic associated steatotic liver disease, metabolism associated steatotic liver disease, MASLD as we call it. Earlier it was called as non-alcoholic fatty liver disease, the gallstones, infertility. All these are because of the metabolic changes that happen with obesity. Now we have mechanical aspects of obesity. Because of the mechanical problems, you have osteoarthritis, knee osteoarthritis. You have problems like incontinence. You have problems like asthma. You have problems like chronic back pain, or you could even get sleep apnea, obstructive sleep apnea. So all these, and GERD are all the mechanical complications of obesity, mechanical complications of obesity. Then, when you look at the mental aspects, mental complications, you have got depression, anxiety, and such problems happening because of the psychological aspects. So there are several. We could categorize the complications of obesity as metabolic complications, mechanical complications, and the mental complications. And what we see is that there is a strong evidence that many of these that obesity is linked to many of these diseases. As you can see, if you put them all together, you can say that there are 229 different complications affecting almost every organ system that has been linked to obesity. And therefore it's very important that we should understand the implications of obesity, and also the understand the fact that obesity leads to a decrease in life expectation, as is shown in this cartoon. You can see that there is a, with increasing BMI, there is a reduction in life expectancy, and with a BMI of between 40 to 50, there is a 50% chance of reaching the age of 70 years. And the prevalence of complications increases as the BMI increases. And yeah, this gives an illustrative view of what is the percentage of various complications. So this is in a person with a BMI of more than 30. You could say what is the chance of having myocardial infarction is about 21%, having mast cell or non-alcoholic fatty liver disease 29%, 35% chance of having GRD symptoms, and about 40% chance of having obstructive sleep apnea, and so on and so forth, as you can see, and 21% chance of having diabetes, as you can see here. So these are the various problems and the relative risk of obesity. Now let us understand how should we define obesity, because all these while we used to speak of obesity being a condition associated with excess body fat, but it's not so. It's not just that there is excess body fat, but obesity today, if you can see, I've just taken the Canadian definition of obesity, and because that describes it very well. And in fact, many other organizations have taken this type of definition for obesity. So obesity can be defined as a complex chronic disease in which abnormal or excess body fat impairs health, increases the risk of long-term medical complications, and reduces lifespan. So, obesity is today recognized as a disease and a health issue according to numerous global guidelines. And all those are shown here. As you can see, the World Obesity Federation has spoken of obesity as a chronic relapsing uh, progressive disease with need for immediate action for prevention and control of the global epidemic. And similarly, as you can see, various other organizations have also defined obesity as a progressive disease impacting several severely on individual and the society alike. Obesity is the gateway to many other diseases. This is what the EASO, that is European Association of Study of Obesity, has spoken of. So all the organizations across, all professional organizations across the globe, are now recognizing obesity as a disease which needs to be addressed effectively, and we need to look at solutions for treating obesity and not just passing it off as a risk factor for other problems. Now, how do we classify obesity? So this has also been in focus in the last few years. You can say that the body mass index has been a common parameter that has been used for classifying obesity. We used to speak of body mass index when we look at body that's defined by the weight and height. So the weight in kgs by the height in meter square gives the body mass index, and the body mass index, what is considered to be normal for our population, is between the range of 18 to 23. About 23, we call it as between 23 to 25 is overweight, and beyond 25 is obesity. So this is how obesity has been classified. And now what we also see is that we said that in our population we may not find people who are obese, and this classification of BMI also, lower cutoffs are used for our population because we see that we tend to develop the problems associated with obesity at lower BMI. Now, when you look at the waist circumference as a measure, waist circumference is again a measure of obesity, because sorry, so sorry. Can you see my slides?
Yes, sir.
Waist circumference is a better measure nowadays, because what we see is that this helps in identifying the central obesity, and that gives us an idea about the prevalence of central obesity. And what we say is that a waist circumference of more than 80 centimeters in males and 80 centimeters in females and 90 centimeters males indicates the presence of obesity in our population. So measuring abdominal obesity, or by using a simple measure like a waist circumference, is very important. While there are other ways of measuring the body fat, when you're looking at the DEXA or MRI for doing a body fat measurement, a body fat percentage of more than 25 and more than 25 or more than in in males, and more than 30% in females, is considered to be indicator of obesity. So that is another way of defining obesity. Now, when you look at the BMI and the waist circumference, every time it may not give us the true measure of obesity. So what is suggested is the Edmonton obesity staging system, which has actually put in the components of the clinical components also. And when you add these clinical components, obesity can be divided into stage 0 to stage 4 without any of the other components, and stage 4 where you have end stage, you have the clinical components added on. This is further exemplified very well by the American Association of Clinical Endocrinology, which has actually defined obesity as preclinical obesity, where there are no obesity related complications which are not affecting any of the quality of life. And then you have clinical obesity, where you have the obesity complications with symptoms, organ involvement, and going on to development of diabetes, cancer, and MASH. So so this is how American Association of Clinical Endocrinology has given the classification of adiposity-based chronic disease, or ABCD. It has put up what is called as ABCD, and this is putting in the various clinical aspects about obesity itself, rather than just defining based on the anthropometric parameters. So when you add on these individualized, this will help you in individualizing treatment plans and deciding on the therapeutic goals and treatment. So, if you look at diagnosis of obesity based on this ABCD categorization, you say that you can evaluate the presence and severity of obesity related chronic diseases that are there. Those have to be looked at. Particularly look at the presence of diabetes, hypertension, look at cardiovascular disease, or look at MASLD. And when you look at these cardiometabolic, biomechanical, and other factors, then you can classify them as to stage 1 obesity when none of these are present, stage 2 obesity where there's more than one mild to moderate obesity related chronic disease, and if there is more than one severe obesity related chronic disease, then you put it as stage 3 obesity. So this is how they have very nicely put up the categorization of obesity as clinical obesity uh, and and uh, and and looking at the various aspects of obesity. Similarly, we have a new system which has been proposed in the Lancet Commission also. Dr. Anup Mishra and his group have actually given us a good classification, saying that you could categorize obesity as stage 1 obesity where the BMI is more than 23, but you do not have any symptoms suggestive of limiting day-to-day activities due to obesity, and no obesity related chronic diseases. So in that you call it as stage 1 obesity. But stage 2 obesity is where you have a BMI of more than 23 and you have some obesity related related limitations, and obesity related chronic disease which is limiting the activity of the individual. So let's move on to understanding treatment now. After having understood how to categorize obesity, how to define obesity, let us look at obesity treatment. But if you, the major problem that we see is that although if there are 100 people living with obesity, there are only 40% of them are diagnosed with obesity. And if you look at these 40% also, only half of them are actually getting any obesity related evidence based treatment. And those who are prescribed obesity related treatment is only 1%. So if out of all the people living with obesity, probably only 1% of them are actually getting evidence based treatments for obesity. All the others are aware that they have obesity. There are 40% of them who are diagnosed to have obesity, but and 60% of them are not even diagnosed that they are obese, and they're not realizing the fact that they are at risk of various complications. What are the benefits of treatment? If you are able to bring about 5% weight loss, you bring down hypertension, you bring about a significant benefit in the glucose levels. And when you have 5 to 10% weight loss, you have improvement in PCOS, you have improvement in non-alcoholic fatty liver disease, you have prevention of type 2 diabetes, and go on to about 10 to 15%, you have improvement in cardiovascular disease, urinary stress incontinence, knee osteoarthritis, non-alcoholic fatty liver disease. And as you see, as more and more weight loss obtained, you even get remission of diabetes, hepatic steatosis improves, and there is also improvement in heart failure with preserved ejection fraction also showing improvement. So this is the benefits of weight reduction. As the weight reduction improves, when there is greater and greater benefit seen in terms of various complications of obesity. So weight loss also improves the CV risk factors, and you can see that with lesser weight reduction, some smaller weight reduction, you have some benefits. With greater weight reduction, you have more and more benefits. And as you can see, but the major problem that we should see is that as we start getting weight loss, there are adaptations that resist weight loss. Hormone levels will change. There is decrease in satiety hormones, increase in the hunger hormones, and also the metabolic expenditure rate keeps decreasing, and that's why weight regain happens. So that is the major problem that we need to look at. So what are the various pillars of obesity management that we should look at? Is one is the lifestyle changes are recommended, behavioral interventions, pharmacotherapy, and when we want more and more weight loss, then we have surgical interventions and endoscopic procedures, about which we're going to hear soon in the next presentation. But before that, I'll speak a little about speak a couple of more minutes to speak about the medical management of obesity. As you can see, we need to look at not only the nutritional aspects, advice about the diet, but also advise people about physical activity, behavioral interventions, and reducing the sleep also. And these are the important aspects that we should understand, that if we adopt a weight centric approach, then we are likely to have a better reduction in various complications that we are speaking about. So we should ask the patient for permission to discuss weight, assess the history of the patient, advise the patient on treatment options, agree on certain treatment goals, and assist in the long term weight management. And so these are the five A's that we should keep in mind when we are when you're going to treat obesity, and they are going to help us for a successful weight loss journey. And we should advise people to eat healthy, increase physical activity, hydrate, and get enough sleep, and manage stress also. And I will not discuss much about the dietary management, but here is what we should look at. We should use the plate model, which is very important in giving people to understand about how to distribute their calories, how to reduce the calories, and how to distribute between the proteins, between the carbohydrates, and increasing the vegetable intake. Now, when you come to medications which are available, you can see these are the various timelines of various medications coming into the market. And today we have the GLP-1 analogs, and even we have the GLP and GIP analogs, which have made a significant revolution in the management of obesity. So, how do you decide about which type of medication is going to be used? If you're looking at people, I mean, those you need to decide whether you're looking at just the biomechanical benefits, or you're looking at uh, diabetes management, prevention of MASH, chronic kidney disease, blood pressure lowering effect, the MACE prevention. All these are provided by different agents. As we can see, we have different therapies available. As you can see here, with the available therapies like the GLP-1 analogs, semaglutide and liraglutide. In you could obtain benefits in terms of cardiovascular disease prevention. When you're looking at blood pressure, you're lowering. You have agents like the GLP-1 analogs. In addition, even phentolamide, topiramate have been shown to have benefits on blood pressure. Semaglutide, tirzepatide have been shown to have effects on reduction of chronic kidney disease, reduction of MASH, and reduction of the heart failure also. And when you're looking at, and they've also been shown to have the benefits in terms of biomechanical benefits in terms of osteoarthritis and obstructive sleep apnea also. Now, when you're looking at lower cost therapies, we have some of these therapies. We have only orlistat available in our country, while in by FDA approval, you have some other agents also approved by FDA, but many of them are not available in our country in the formulation that they are approved. And so, therefore, we'll restrict our discussion to what are the benefits with the GLP-1 analogs, and which have been found to be effective agents for management of obesity. If you look at the benefits that you have seen and the efficacy of currently available agents, with orlistat, you tend to get a less than 5% reduction in weight. Liraglutide about 5% reduction, and all the other phentermine and naltrexone buprenorphine, you again get about 5 to 6% weight reduction. 10% with phentermine topiramate combination. Semaglutide about 12.5%, and almost 20% with tirzepatide. The main mechanism action of these GLP-1 analogs is mainly through their direct action on the hindbrain, suppressing appetite, and also direct actions on hypothalamus, in addition to their effects on the GI tract in terms of reducing the bowel motility, reducing the gastric I mean output, and in terms of reducing the increasing satiety. So in the STEP program, which was a phase 3 program with semaglutide, we could see that there was a significant weight benefit seen to the tune of about 16.9% reduction in weight with after 68 weeks with semaglutide. And when you look at the sustained weight management over 2 years of use of semaglutide, again you could see 18% reduction in weight happening with the use of semaglutide in the dose of 2.4 milligrams as compared to placebo. And if you look at the percentage weight loss seen in different categories, you could see that 86% of patients could achieve a weight loss of more than 5%. And when you look at a 20% weight loss, you could achieve that in about 30% of the patients. In the step 1 trial, similar results were seen in most of the other trials, with about 30% weight loss seen in the step 4 trial as compared to placebo. Now, there are effects beyond weight reduction in terms of CV risk factor reduction, glucose metabolism, and also other weight-related benefits were seen, and changes in body composition with a reasonably good safety profile, with major problems being the GI disturbances. And if you look at the MACE reduction, you could see 19% reduction in the risk for all cause death, 22% reduction in developing kidney disease, and 73% reduction in risk of developing diabetes. Again, a very impressive benefits that are seen, and it improves the functional outcome and several other benefits as we have spoken of. Now, when you're looking at tirzepatide, which is a dual GLP-1 GIP agonist, it has some additional benefits over the GLP-1 agonists themselves, and because it has got it one of the major benefits is probably in terms of reduction in nausea because of the effects of GIP, which reduces nausea. And the Surmount studies have given us some has given us benefit. I mean, the evidence for the clinical benefits in patients where it has been used in different clinical scenarios, and you can see that the percentage body weight reduction that has been seen varies from 16% with 5% 5 milligram dose, and going all the way up to 22% with the 15 mg dose of tirzepatide. And the absolute the all the other studies have also shown similar benefits, with a reduction in the waist circumference also going up to about 19 centimeters with the 15 mg dose of tirzepatide. And the number of participants achieving more than 5% weight loss has been to the tune of 96%. And when you look at the number of participants achieving a weight benefit of more than 10% has been to the tune of 94%. When you come down to seeing more than 15% has also been seen in almost close to about 80% of patients. And when you look at more than 20% weight loss, it is seen in about more than in about 60 to 70% of the patients. So clearly showing that there's a significant benefit in terms of weight reduction with these new agents. So what we are saying is that obesity must be treated based on evidence to improve the health outcomes and the patient well-being. And most clinical guidelines today are and international professional associations advocate for long-term weight management focused on improving health outcomes and well-being, and not just weight loss, looking at all the health outcomes, improving the health outcomes and well-being. So obesity, we know that it is leading to multi-organ dysfunction, and we are recommending long-term treatment looking at improving all the health outcomes and well-being, and not just looking at the weight management itself. Long-term pharmacotherapy should be an integral part of standard care for obesity management. Most people with obesity can achieve sustained weight loss, health benefits, and improved quality of life with proper obesity care. And across the globe, all clinical guidelines today speak of uh, uh, of focusing our attention on improving the health outcomes and well-being, and not just looking at the weight loss itself. Looking at the overall quality of life is more important than just looking at this or at the weight itself as a number. So with that, I'll conclude, and I thank you all for the patient hearing, and I'll be happy to answer questions in the end.
Thank you so much, sir, for exceptionally insightful presentation, sir. Your clear explanation for the hormonal and metabolic factors driving obesity truly underscores why we must treat this chronic disease, sir. And we are greatly appreciate your detailed overview of this non-surgical management options. Sir, we will take questions after when both the presentation end. Moving forward, now we move as of advanced obesity care, and it's my pleasure to welcome our second speaker, Dr. Nanda Rajneesh ma'am, to present the surgical perspectives. Dr. Rajneesh ma'am will outline when how bariatric surgery fits into the multidisciplinary approach. So, ma'am, over to you, ma'am.
Hi everyone. Thank you for this organization asking me to make a presentation on obesity as a lifelong relapsing chronic disease, and it is driven by biology and not the personal failure. Because there's a lot of guilt in all obese patients and all of us gaining weight. We say that, okay, I eat a lot and I'm putting on weight. So, how do we attend to this to ourselves? It is a biology and we need help. Like we say, when we have a lot of disturbance in mind, we have to go and meet the right person. When we have particular disease, we go and meet. There is a help, integrated specialists, surgeons, medic physicians, as the previous speaker spoke. We need to understand obesity differently now. Now, obesity was very well explained what exactly is obesity. I like to say here we should know two things in obesity. One is basal metabolic rate, that is energy expenditure. So, the amount of food that each and every cell can burn, or calories that every cell can burn. Now, when there is obesity, there is a complex distribution of fat cells around the normal cell. So this distribution of fat cells around the normal cell create kind of uh, mm, a mesh where the food may not be able to enter, or the basic metabolic rate of a cell itself is reduced. So when that happens, it becomes a vicious cycle. Whatever food you eat, it goes on accumulating and accumulating. Okay. Now, another entity is body mass index. Yes. When, as a surgeon, I like to say, okay, when do we operate? When we think that BMI is above 35. BMI was described by the previous speaker very well. Now, below between 30 and 35 also we consider it to be obesity. And the distribution of fat is different in different people. In Indian setting, we see a central abdominal obesity. Some people can have a limb obesity. Some people can have overall upper body obesity with whole body obesity. So this variation is probably due to kind of diet we take, because in India we take mostly lentil based diet. So probably there is an inflammation due to certain diet, nutrition, and gut organisms which play a big role, causing central abdominal obesity, and it is definitely associated with many diseases. Now, to going back to a little bit of history of this obesity is, in 1975, World Health Organization reported it as an urgent need of public health. Okay. And after that, not much importance of given was given by neither the physician nor the endocrinologist. Suddenly there was a huge spike when the surgery came into big perspective. That is when physicians, endocrinologists also started taking a very big role and understanding the disease to the depth there. And now we have a medical gastroenterologist also playing a very big role in this. Now, obesity as a complex issue was very well discussed as a causes of obesity by the previous speaker. One thing I like to say, genetic predisposition may be also associated with the family people having a same poor diet, high calorie diet, high fat diet. Earlier we used to think it is rich man's disease. Obesity was a rich man's disease, but now we know it is present even in the low socioeconomic group. I like to say, even a lot of times poor people are given the kind of diet, or they're eating kind of food, and now there is so much of contamination of diet nutrition all over the world. So that is also contributing in a big way, and availability of a diet nutrition in particular environmental factor plays a very big role. And medical conditions have been discussed extremely well. But here I like to say, what caused what? Did the obesity cause the medical condition? Or, like, for example, a lot of my patients say, Madam, I have polycystic ovarian disease, that's why I'm obese. Did obesity cause polycystic ovarian disease, or polycystic ovarian disease caused obesity? So I like to, as I take it forward, we will get to know what exactly happens in the body when there is obesity. When you see this picture, it looks like a bag that is filled with multiple organs and lot of fat also in the bag. So this is what happens in obesity. So what happens is, when the normal cell is surrounded by obese cells, the obese cells are known to attract a lot of inflammatory factors, known to release a certain abnormal estrogen like factors. We know that in breast cancers, that estrogen like factors it releases, and many other hormones also it may be releasing, and it causes damage to the normal functional cell, and it also alters the receptors on the normal cell. It also removes or maybe makes the intercellular junctions abnormal. So, by this, obesity is known to cause many diseases in different organs. So, it will not leave any organ in the body. And as a surgeon, I like to take you that obesity is definitely linked to several types of cancers. So, what is a cancer cell? Is an abnormal cell which is continuously multiplying. It starts as one single cell. We know that our body produces millions of cancer cells or abnormal cells at any given time, and our body has also capacity to do the programmed cell deaths, that is killing our own bad cells. So does fat cells around the normal cell, are they preventing the the natural killer cells or cell mediated immunity reaching the abnormal cell to kill it? So the reason for increased risk of cancer could be chronic inflammation, hormonal shifts. As I said, they are known to produce certain factors which can block the normal receptors and which can increase the chances of cancers, and insulin resistance and adipokine imbalance also. That is, the fat redistribution is abnormal. Now, obesity also increases the risk of various infection. As a surgeon, I like to give a little bit of attention to this particular topic because we're always worried of cutting the fat tissue and then going through the normal tissues into the, especially abdominal surgeries, any skin surgeries. So the wound healing is bad. We call it a fat as a surgeon's enemy, so we know that. So now it can cause many infections. Now infections and obesity connection became even more established during COVID. So they established the fact that there were a lot of COVID infections in obese patients, and the prognosis of COVID infection was very bad in obese patients. So, and we also find wound healing is common. Wound dehiscence post surgery is very common in obese people. Now, health risks have been discussed, but especially diabetes and cardiovascular disease take a very big lead. And this is the reason we have to treat obese patients, especially physicians and endocrinologists focus a lot on this. They are the one who are referring the patients to surgeons. So over a period of time, a lot of surgical indication comes from physicians. So we should always, as a surgeon, we always have to keep that in mind. Now, psychological effects. Here it is two-way. Whether psychological effects started with obesity or obesity gave us psychological bad effects, we have to look into this. So I have seen quite a few obese patients doing very well mentally also and successful too, but we have to see that extreme, like a morbid obese patients, that is when the BMI is above 45, 50, their self-esteem is very low, there's depression, and there is a mechanical problem, the walking is affected, they may not be able to do a lot of physical activity, and there is a huge quality of life impact. Now, what constitutes weight loss? So we need to look at making this patient lose weight. How do we do that? What is actually weight loss first? Weight loss is what we lose both fat, we lose fat, we can lose muscles, and we can lose water. Because we say, like, whenever patients start losing weight, within 5 days or 10 days, 15 days, we start losing more weight. So that is water loss, we say. And gradually then there is a fat loss. Then if it is aggressively you lose weight, it becomes an unhealthy weight loss, there where you lose muscles. So you need to know healthy versus unhealthy weight loss. So what is important is sustained weight loss is extremely important. Sustained weight loss focuses on long term lifestyle shifts and habit changes. And even if you are slim, you, after a certain age, we should know that fitness should become part of our life. We knew that we all had to be fit as children. We in the school we were taught to do exercises, but we were never told this has to be part of your life. How you brush your teeth, exercising and being fit is a part of our life, because exercises and fitness cleanses your body. It cleanses, takes away the inflammation from all the musculoskeletal system and different organs of the body. Now, how can we do weight reduction? There are certain strategies, but dietary changes make a big role, because it is all about energy intake, energy that we burn. But the mechanism is different in different people. But what dietary changes we make, we have to give a lot of attention to eating local foods, especially fruits, vegetables, and lean proteins. You know, the at one time taking high protein became big fashion, I would call it, and a lot of people would uh, take, high protein diets, and that even caused a lot of health side effects, and it caused gut dysbiosis, we call it. And so we need to really balance the proteins and take it in the form of lean proteins, that is a lot of veggies that contains proteins, and brown rice, and locally available fruits and vegetables, very important. I'm going to talk to you about diet even more in detail a little later. Physical activity recommendations are, yes, CDC is recommending 150 minutes a day, moderate intensity aerobic exercises. What are these moderate intensity exercises? They're called low metabolic exercises. Low metabolic exercises are known to burn intercellular fat. That's there are two cells in between. There is a lot of fat. So if you do a lot of energy burning exercise like treadmill, running, jogging, if you do, what happens is you burn a lot of calories, yes, but you come back and eat probably little more calories. So you have to combine both the exercises, is very very important. So how do you do this 150 minutes? Probably you can make it twice a day if you're very focused, but suddenly don't start 50 minutes exercise at the age of 40 or 45. So you need to know what is good for your body, and trainers and physical fitness trainers and physical therapist can also help you to help you in adapting your type of exercise that you can do. And yoga is a very good low metabolic exercise. And behavioral modification, certain behavioral changes, how you eat, and set up a realistic goals. And you can actually make a habit of eating food at a particular time. Maintaining the biological clock is very very important. That is one. And secondly, if you're obese, then you can skip one meal with just low food of low glycemic index. So, how do you do that? You know that as Yoshinoru described about intermittent fasting, but that can be done every day fasting. That is, you eat early dinner around 6 o'clock, and next day morning you eat breakfast at 10 o'clock. In between, as much as possible, not to take anything. So, fat cell being a bad cell, it, that also has to die in our body. That is programmed cell death of a fat cell. So programmed uh, killing of the fat cell also has to happen, or burning of the fat cell, I would call. And gradually you need to focus on increasing your metabolic rate, basal metabolic rate. Now, what in I kept saying that this is a kind of biology. The disease obesity is a biological disease. What do you mean by that? There is an inflammation. The inflammation may be caused by gut organisms, or it can be caused by antioxidants in the diet. What do they do? The oxidants basically damage the phospholipid surface, or peroxidize the phospholipid surface of a cell. With this, the cell membrane integrity is lost, and the basal metabolic rate is altered. If you eat antioxidant diet, I'm sure you all know what is antioxidant diet, rich in vitamin C, E, and zinc, iron, copper. Of course, all this is shifted because of the chemicals and pesticides we are using in the diet. So we need to look at probably supplements in obese patients if there is a deficiency. So as I said, how do we exactly work towards again weight reduction? So we need to bring a calorie deficit. This calorie deficit can be brought in many ways. One is you take low glycemic index foods of low glycemic index, eat intermittent small meals so that the stomach tonicity increases and stomach becomes smaller in size. When stomach becomes smaller in size, amount of muscles increase, the tonicity of the stomach increases, then you feel full with small quantity of food, you eat less and you become more energetic, you burn a lot of calories. The lot of fat as a calories, and that is a different shift in the mechanism of the energy burning has to happen. And uh, what else you have to do? Probably, as described by the previous speaker, medication and then surgery. This is how you, that is main principle of weight reduction. Nutritional balance is very, very important. As I said, there are many diseases associated with the uh, obesity, especially vitamin D deficiency, B12 deficiency, protein deficiency, or protein intolerance, gut dysbiosis. So all these need to be attended to. So we need an interventional therapist or multiple specialists taking care of the patient. So long term lifestyle changes includes making lasting changes in lifestyle itself, how you work, how you sleep, and how you make your daily routine, how you exercise, and there has to be some consistency in what we do. Now, role of pharmacotherapy has been very well described by the previous speaker, but there are certain indications definitely for drugs. Here we are actually targeting the central nervous system cells, so we need to be very careful. Patient has to be explained about the side effects, one, and secondly, it has to be also patient's preference to take pharmacotherapy for weight loss, and patient has to visit their doctor very regularly. Occasionally, in patients who are contraindicated for surgery or endoscopic therapy, we do give these drugs, and pre-surgically also there is an indication for medication for a very short time under monitoring. So these are the different receptor drugs which has been very well described by the previous speaker. Probably I will skip this, but you should note the side effects are related both CNS side effects and gut side effects. And one of the lipase inhibitors was very well described and very well used previously. I think now usage has slightly come down because of the fat absorption defect that it creates, because fat is also needed for our body. Now, when do you plan to do surgery? When the BMI is about 35 is when we want to operate the patients, or the failed other treatments and weight loss programs and associated with the diabetes, type 2 diabetes, hypertension, sleep apnea, joint problems, cardiovascular disease. These are definitely indications for bariatric surgery. Okay, and making the patient psychologically ready for the surgery is extremely important. As soon as the patient comes, let's not say, okay, you need surgery, let me start doing the surgery in a week's time or tomorrow or in third day, in 3 days. So we need to prepare these patients very well because they are associated with many organ diseases. So we need to correct organ disease problems with the help of endocrinologists and physicians. And preoperative workup is extremely important. In the workup, we look for any organ failure or hypothyroidism, hormone imbalances, any nutritional status of the patient, like deficiencies, and sleep apnea. If it is present, we need to actually ask pulmonologist to help us to stabilize the patient. And gastric endoscopy is needed in all these patients to rule out presence of gallstones. It's very common in obese patients, gallstones. And um, and because if we are doing bariatric surgery, we as well also do surgery for gallstones, and other investigation may be done as directed by other clinical condition of the patient. And nutritional support is very important. Now, what is nutritional support here? Basically, when we prepare the patient, see, what is surgery? Surgery is where you restrict amount of food you intake. That is, the stomach is reduced in size, and or you restrict the amount of diet you take. So patient needs to be prepared what type of foods to take, how, what is the food of low glycemic index, or how to make smoothies, how to, nutritionist comes in a big role here, pre-operatively. When you start giving liquid diet to patient for 2 weeks, The liver also gets firm because the amount of fat first gets reduced in the liver itself. So liver starts improving because we are, when we do a gastric sleeve resection surgery, we need to retract, or any abdominal surgery we do, so especially on the stomach, we need to retract the liver. Liver has to be firm. The bleeding complications will be less. So just to discuss, take you to types of surgeries: vertical sleeve gastrectomy, gastric bypass, and balloon placement. How we do sleeve gastrectomy and what exactly it is. In gastric sleeve resection, basically we cut the stomach to a tube here. You see here, the first picture, we make a stomach into a tube where not more than 100 to 150 ml of diet can go into the stomach as soon as surgery is done. So this is very commonly used surgery, and it gives a very good success rates in patients, and it is much simpler surgery compared to gastric bypass surgery. Gastric bypass surgery is suggested only in morbidly obese patients. Here in gastric bypass surgery, you make a small pouch of the stomach, and you also divert all the gastric juices distally, so that absorption, there is a malabsorption created in the patients. But in balloon placement, this is also restrictive surgery where your stomach is already filled with a balloon, big balloon, and now endoscopists are placing these good silicone balloons, and they have actually reduced number of sleeve gastrectomies that are being done. How do we do gastric sleeve surgery is, normally patients are well prepared, as I discussed before the surgery, and uh, we do laparoscopically this surgery. Laparoscopically, this surgery is done. We put 3 to 4 to 5 ports. We put, and first we retract the liver, and the stomach is identified very well, and we actually bear the stomach from the mental attachment and gastrosplenic ligament attachments and the blood vessels also. They're clipped and detached, because the principle of gastric sleeve resection is not just restrictive surgery. There's one more component to it, that is fundus of the stomach, because we keep eating till the fundus is full. So the fundus also has to be removed, because ghrelin and leptin hormone stimulation and depends on the fundus getting filled. Okay, so now we have to remove the fundus. So that is the reason we place a bogey in the stomach, and we use a stapler. Three layer staplers is used now. They're available from different companies, and we staple the stomach along the bougie. And near the gastroesophageal junction, we should make sure we don't go very close to the esophagus, because the valve should not be damaged here. That's very important in this surgery. And post surgery, what do we do is, patients patients are put on a liquid food for 3 to 5 weeks. In fact, it is short stay surgery, or I would call it decade surgery. Within 24 hours we can discharge the patient, but uh, we uh, we actually have to monitor the patient very well. We have to ensure, because if they have some psychological component, they may end up going and eating the solid food, or suddenly some meat or something like that, and they can stretch this staplers that are placed. The leaks can happen. That is one of the common complication post surgery. And other complications also are, okay, uh, other complications include, apart from the leak, patient loses massive weight in first 6 months. With the loss of weight, there is a hair fall. I'm going to next slide here. Before this, okay, first let me talk about complications. It can lead to nutritional deficiency. It can lead to leak is one of the early complications. DVT is very common, so these patients have to be mobilized very quickly. And loss of skin, subcutaneous fat. So because subcutaneous fat plays a very big role in keeping the skin intact, the skin can sag for these people. So you have to balance the nutrition very well. The nutritionist plays a very big role here. Anti-inflammatory diet. So now going back to these two slides, what exactly happens post surgery is there are a lot of benefits in the gut bacteria. That is what is described. One is you eat a very small meal. You cannot stretch stomach. Avoid eating wheat foods because bread and wheat diets can stretch the stomach in long term. That is the reason for failure of the sleeve resection. When you do a sleeve resection, I always tell my patients, okay, uh, you can eat a lot of foods even post surgeries. The misnomer with the bariatric surgery is that, oh, I can't eat after the surgery. You can eat after the surgery, but you may end up stretching the stomach. Even after balloon replacement, you need to eat diets which are easily digestible, and also nutritional balancing, very very important. One of the major benefit is shift in the microorganisms in the gut. Why does this happen? We know that there are certain bacteria need certain foods to grow. So, and they also produce certain enzymes, they also produce certain toxins. So, when you give less food in the gut, normally it is not possible. Okay, we may stop eating for 15 days, and 16th day again you start eating. That is why normally the diet advice alone is known to fail in the long term. That's why diet, nutrition, lifestyle, exercise, all is needed. Now, when you give low the certain diets of antioxidant diets, I would call, they reduce the inflammation, and the gut mycobacteria or microorganisms improve a lot, because gut dysbiosis theory is one of the theories that is for the obesity. That is, and providing the patients with vitamin, nutrients, and protein balancing. Some protein is needed, definitely is very very important, because hair fall is also very common. Extreme hair fall, the hair loss is very bad in some of these patients. So very important. Now, what is beyond weight loss? Okay, whether I have done surgery, I have given medicine, patients are losing weight, okay, they have lost weight, and how do we maintain healthy lifestyle? That is very very important. Okay, what is beyond weight loss? Again, is a lifestyle, nutrition, again physical activity. Make mental and physical well-being as a lifestyle, as a routine. Like, you go out every day without brushing, you don't go out, right? Without taking bath, that is externally you do. Mouth you wash, you take bath, you clean yourself. When you exercise, you cleanse your musculoskeletal system. Okay, and you have to address underlying health issues, hypothyroidism, whether it is polycystic ovarian disease. So nutrition also play a role, but there are certain hormone requirements to correct these underlying health issues. And follow up regularly with your physician or endocrinologist, whoever you are going to. There can be an interventionist in some countries who take care of the obesity, so you need to go to them. Now, very important to know how to boost your basal metabolic rate. So now, how do we do that? Resistance training can increase muscle mass, which burns more calories at rest. Okay, resistance training is certain exercises like yoga, where you lift your own body, boxing, and weightlifting. These are all resistance training. Now, high intensity activity, as I said, you may burn a lot of calories. You may end up eating. That's why balance with resistance training and high intensity activities. Get good sleep, because in sleep we burn a lot of calories, because basal metabolic rate is round the clock, 24 hours. Some people say, oh, she eats a lot of food but she's still slim, or he eats a lot of food but he's still slim. That is because his basal metabolic rate is very high. Okay, and eat foods rich in proteins that are easily digestible, and stay hydrated. Hydration is very very important. Some people avoid drinking water late evenings. That should be, as much as possible, just drink and hydrate yourself, very important. Correction of nutrition, nutrients, vitamins is very important. And there are certain foods, antioxidant diets, which can increase the basal metabolic rate. You can look into that. Thank you very much for listening to me. Thank you.
Thank you so much, ma'am, for the highly comprehensive overview. And your presentation is like really complimented Dr. Shah sir by showing the complete spectrum of care, particularly the critical role of surgery in complex cases, ma'am. It was great, a beautiful presentation, and very much helpful to all the participants and going to help them on their day-to-day practice too. Ma'am, moving forward, I also welcome sir, and for both the presentation, it was very comprehensive one. Moving forward, ma'am, like we would like to move to the question answer round. Like we have received several questions from the participants. Sir and ma'am, with all your permission, shall we good to go for the question answer? Sir, with all your permission, ma'am, shall we start?
Yeah, sure, you can.
Yes. First question I will ask Dr. Shahai sir. Sir, how do we clinically identify patients whose obesity is driven primarily by hormonal or metabolic factors rather than lifestyle, sir? What's your point of view on that, sir?
Yeah. So as I mentioned earlier in my presentation, that the prevalence of hormonal disturbances causing obesity may be lesser. It's not that common. It's only about 5% of all patients with obesity are actually driven because of these hormonal disturbances. So I think those are identified by clinical appearance itself, because they have typical presentations, and also by assessing. So appropriately you look for thyroid profile, do a thyroid profile, which we do in most of our patients, almost all of our patients. And then where you think that it's because of excess cortisol secretion, you have tests to do, that you need to do a suppression test, dexamethasone suppression test, to confirm that there is excessive cortisol secretion which is happening beyond the feedback control. And similarly, growth hormone can be a factor. So those are, they are defined clinical presentations which can be identified, and which can, I mean, I didn't go into discussion of that because that is beyond the scope of today's discussion. But yeah, the clinical presentation itself helps us in understanding that.
Thank you so much, ma'am. I hope it will be very much helpful to all the participants. Moving forward to another question from Dr. Nanda, ma'am. And ma'am, what are the current indications for bariatric surgery under new guidelines? Can you please share some point on that?
Uh, Basically, BMI about 35 is one of the indication and patient's preference. So a lot of young patients, let's say between 20 and 28 or 31, even if BMI is 35, we still 30 and above. If the patient preference that they want to lose early weight immediately, we can consider operating on them. And then diabetes mellitus, we know that by doing bariatric surgery, the many diseases like hypertension and diabetes mellitus are known to improve. So even with a low BMI, we can operate them. And gastric sleeve resection is a preferred surgery that we do now. And that is morbid obesity is one of the indicators for gastric sleeve resections. But now the indication is definitely shifting recently because we have a very good endoscopic balloon placement. We have excellent silicone endoscopic balloon placements that has definitely changed the indication for bariatric surgery.
Thank you so much, ma'am, for sharing some point related to bariatric guidelines, ma'am. I hope it will also going to help all the doctors who have joined this live webinar on their practice too and for their knowledge purpose. Moving forward, we have another question for Dr. Sahay, sir. Sir, what are the biomarkers or clinical indicators help predict weight regain, sir? Can you please share some point on that?
Well, I would say that the best biomarker is the weight itself, because weight, as I said, there are compensatory mechanisms coming into play, which will, the weight reduction will not be the same as happened, say, in the first 1 month when a dietary therapy started, dietary change is done. What is initially lost may not, the same degree of weight loss may not happen over the next few weeks. I mean, the coming weeks, because of the fact that there is this adaptation. So we need to continue and go on, and not expect the same degree of weight loss which happens in the first couple of months. You have a much better weight loss than what happens with the same measures being continued over the next few months. So I think uh, but I'm not I'm not sure of any biomarker that can detect this, but the weight itself, the response that we're seeing is itself is a indicator of what is happening. Madam
Thank
may
you
like
so
to
much,
add
sir,
something.
for answering. Yes, sir. Sir, very well taken, sir. And the weight gain is already a indicator for this obesity. Very well explained, sir. I hope again it will be helpful. Moving forward, we have few more questions. The second question for Dr. Nanda, ma'am. What are pre-operative assessments should GPs and physician complete before referral, ma'am? What are the things need to be take care? What's your point of view on that?
I would say look for hormonal imbalance, hormones, especially hypothyroidism, and nutritional imbalance they look for, and their sleep. If there is a sleep apnea present, the sleep studies, and they can complete these, and they can decide should we really operate, or they want to consider even referring them to medical gastroenterologist for endoscopic placement, because sometimes patients are not even at any cost, they're not fit for surgery at all. So the diabetes mellitus, chronic obstructive pulmonary diseases, such patients are not indicated for surgery at all, so they may be directly a patient for endoscopic ballooning. So this has to be kept in mind.
Very well explained and well taken these questions, ma'am. I hope it will be also helpful to all the audience. Moving forward, we have another question for Dr. Sahay, sir. I think this is a very important topic, and we see these type of things in day-to-day OPD practice by GPs. This question is, sir, how should GPs decide when to initiate pharmacotherapy or versus intensify lifestyle interventions? Can you please share some insight on that, sir?
Yeah, so as I was mentioning, that it's like a pyramid where everybody requires lifestyle changes to be addressed, and then some of them require medications. It is those with a BMI more than 27, more than 30, particularly if they are, then they certainly require. And if they have got these metabolic risk factors, then maybe at a lower BMI we may start that.
I hope this is a very important answer given by Dr. Shah, sir. I thought he got some call. Ma'am, would you like to add something to it, like role of lifestyle, or like you see lots of bariatric patients coming to you? What are the role of lifestyle in it, ma'am? Can you please add some point?
Yeah. See, lifestyle includes how you eat, how you exercise, how you work, how you sleep. Maintaining the biological clock is extremely important. Being less stressed, or you have a stress, you cope with it, because stress itself can cause a lot of muscular spasm, and that itself reduces the basal metabolic rate. And then you also should consider exercise as a routine, as I said, and have a trainer if you can afford one. Okay. And or if your complex has a gym, just go there, and you have a lot to learn when you mix up with people who are doing the exercises. But go very slow with it, because suddenly, let's say you have an obese patient, I normally tell her, okay, start skipping one meal and add lots of fruits and vegetables in the meal. That's the first lifestyle that I advise them, dietary lifestyle. And I ask them to start doing slow exercises. Like I wouldn't advise them weightlifting at a time. Low metabolic exercise means weightlifting, but I would tell them go do yoga exercises. Have nowadays a lot of yoga trainings are done online. So you can do yoga exercises. That because there are three categories of yoga exercise also. That is where you do fast intensity yoga exercise and slow exercises. You should go for slow exercises initially, and you can slowly, gradually see how you can increase. And good sleep is very, very important. Have caffeine before 2 o'clock. That is, coffee can reduce sleep and stress also. And working late hours, at least you should minimize number of hours you work, as in not more than 10, 12 hours you should work, and give good time to family members. They say a lot of times See, olden days, one, they used to do a lot of physical activity and they used to do, that was their lifestyle, you know. Olden days, let's say, let's go back to 150 years or 100 years back. They're exercising in the farm, field, and working at home round the clock, and being with the family itself was reducing stress for them. That has gone down. You know, telephone has become everybody's partner and their mother, or what about daughter, whatever. So phone is everything for us now. So we have to reduce our phone time also, and maintaining the biological clock is extremely important. How we set our clock, we have to see. Okay. And if you have any
Thank you
gut,
so much, ma'am.
yeah. Okay. Thank you.
Yes, ma'am. Would you like to add, ma'am, anything else?
Yeah. If you have any gut intolerance, gut dysbiosis, probably medical gastroenterologist can take care of that.
Thank you, ma'am, for again explaining these things in related to obesity, ma'am. One another question for you, ma'am. As we know that this is a very like patient ask, like they have doubts how to deal with these things for all the doctors who are listening out, ma'am. Like, what does relapse or weight regain after surgery indicates clinically, and how should it be managed? What's your point
Yeah.
of view on this question?
Yeah, we have. I myself have come across patients like that, where who regain weight, but the regain is not as much as they used to be before. So regain weight happens because of the stretching of the stomach itself. That is, or the pouch stretches, or you keep overeating, or you go back to normal eating. So regain weight, we normally, there are redo surgeries recommended, of course, but I would say first psychologically counsel the patient on diet, nutrition, and exercise as I described before, and that has to be consistent. Normally, weight loss regain happens if they don't follow up with the team properly. The nutritionist, endocrinologist, physician, there's a team. If they do not follow up regularly, they can regain weight. That is one. If they do not follow the diet, then they can regain weight. If they do not sleep well, if the stress is continuing, because if they are working long hours, or if their family stress is continuing, those things also have to be attended. And I'll tell you, improving your self confidence, you know, having some hobbies with yourself, keeping yourself happy, and that is very helpful in preventing the regain of the weight. And eating
Uh,
foods, lots of
yes,
fruits,
ma'am.
vegetables, as much as possible. Yeah, thank you.
Thank you so much, ma'am, for explaining this very well, ma'am. I hope it will be helpful again. We will be taking, ma'am, like one pointers from both of you on your expertise on these questions, and then we will conclude. Like, we have received lots of questions from the participant, as we know that like obesity has become very much important topic in the medical science, so it need to be focused more and discussed in details. Ma'am, the question is, and sir also, like we will taking one points from both of you. What is the ideal follow-up schedule for obesity patients after initiating therapy, medical or surgical? What's your point of view, sir? Sahai, sir, can you hear us? Sir, can you hear us? I think sir is
Yeah.
facing some issue. Like, ma'am, we meanwhile you can tell your one points, ma'am.
I would say they should meet nutritionist once in a month, physician maybe once in 2 months, any physician or a surgeon once in 2 months after surgery or after the after endoscopic balloon placement. I think medical gastroenterologists could be good at answering this question, but they have to definitely regularly attend to the doctors and tell. In fact, when patients come, we have to ask the patients what is their diet every time. What did you eat morning, breakfast, lunch, dinner in the given last 3 days, 5 days? Because it is definitely calorie intake and calorie burning, weight loss in a big way. Apart from other things, the primary this thing is again diet intake and sleep and other nutritional imbalances to be take whether they're taking medication or not, because patients tend to stop taking vitamins that is recommended to them post surgery.
Thank you so much, ma'am, for sharing the important point to this question. I will request Dr. Shahai, sir, can you hear us? I think ma'am, sir is having some issue, like he's unable to speak right now. Hi, sir, can you hear us? So, ma'am, moving forward, we will take a few more questions, ma'am. Like you can share your point of view to that question as well. Ma'am, how can primary care physician counsels patients who believe obesity is a purely a matter of discipline? What's your point of view on this question, ma'am?
Primary healthcare centers. Okay. First of all, they should know how to help patients to make lose weight. They may be dealing with a lot of people of low socioeconomic status, so they need to be attentive on what kind of foods they're eating, um, because probably primary healthcare center, I would imagine it to be a small town or a small village, or a village or a small town, and what is the kind of food they're following. See, traditionally we were not eating breads, there were no bakeries in villages, they were only in big towns. So stretching your stomach with a lot of food has to be reduced by taking antioxidant diet. What is antioxidant diet? It is more of fruits, vegetables, and avoid too much of lentils and legumes, which bloats your stomach. And you should eat clean food, fresh food, very very important. Not stored foods, not items. A lot of these bakery items like which bloat your stomach. And earlier they definitely maintained biological clock well. Okay, like 2 o'clock break for lunch means 2 o'clock break for lunch, breakfast at this time, lunch at this time, dinner at this time. So those things have to be attended. As I said, that is called biological clock. And sleep pattern has to be studied by them. And of course, as Dr. Physician said, um, definitely, hypothyroidism is one of the common problem in women that we see, not just in women, even in men we are seeing now. One hormone is imbalanced, other hormone imbalance may not show that they should know, because a lot of these hormones have a cyclical pattern. When you study these hormones, they may show normal, but if one hormone is abnormal, always think that other hormones may be imbalanced. Hormonal imbalance, we call it. And nutritional touch is very, very important. If required, put them on multivitamins. Above 50 women, always put them on calcium and magnesium if it is needed. There are multi variety of medications available. Probably you have to supplement them. That's very very helpful right now, because there is a long way to go before we take out the pesticides from this world, and nutrient balance is brought into our context, as how we grow vegetables, fruits, and ask them to eat locally available fruits and vegetables. Very, very important, as much as possible. Okay, and I think I've explained.
Yes. Thank you so much once again, ma'am, for sharing some important points and adding values to that question, ma'am. I hope again it will be very much helpful to all the participants. I will request Dr. Shahai, sir, can you hear us now? I think he is facing some technical issue, ma'am. We will take couple of more question and conclude this webinar, ma'am. Like we have already run out of time. Like the topic is vast, ma'am. And we will taking another question, ma'am. How to address stigma in SCP patient communication, ma'am? Can you please share some point to that?
Stigma. This kind of webinars can help common population, and probably just give lectures in the villages where all the people attend, but don't use that, the obesity is a big problem. Just say lifestyle changes and habits. And so that's one way of taking away the stigma, and telling people that obesity is like any disease, like how diabetes, hypertension, obesity can stay for a long time. So it is like that, because being diabetic is not a stigma. Being hypertensive is not a stigma. Some girls even say, "Oh, I have polycystic ovarian disease. That's why I'm obese." So it's not a stigma. But why obesity is a stigma? So we need to probably speak it as a normal topic, a normal problem, that like how we deal with diabetes, we let us deal with obesity. When obese patient comes with another health issue, see, a lot of times what happens, stigma can be removed this way. I, as a physician, I'm sitting and I deal with some other problem. Patient has come to me with let's say breast pain, but I find her to be obese. Giving a certain tips of losing weight is always helpful, because her pain is related to inflammation in the musculoskeletal system or within the breast also. The pain can be related to her obesity itself. Both may be related. So this is how you take care of the obese patients. Means she's speaking to one-on-one doctor, and okay, don't mind saying that, oh, okay, you have to reduce weight. I think you should focus on that. So, all physicians should not mind talking to their patients who are coming to them for some other problem, but they find there is obesity in them. Giving them few sentences on weight loss is very helpful, I guess. Have I answered
Thank
the
you,
question?
ma'am. Yes, ma'am. Very well explained, ma'am, and very the points are very valuable and like much needed, ma'am. Explained by you. I hope my awareness is very much important. If doctors also make aware about patient that what is the causes and complication can be about the obesity, that will create an impact and better health in the condition of obesity condition, ma'am. Moving forward, we will take one last question, ma'am. Like, what are the practical steps of multidisciplinary obesity management in smaller clinics, ma'am? What should be the approach, ma'am? Can you please share at some point?
As I said, in the smaller clinic also, you can keep one pamphlet, or maybe nowadays we don't keep pamphlets. You can have a television outside, mini television, and you can put some slides where it says weight loss, how you can do, how you can improve your sleep, how diet nutrition is helpful, what is antioxidant diet. Some of these slides you can just keep changing the slides, and they're sitting outside in the clinic. That's one way. And another way, let's say a patient is coming to a orthopedician with body pains or leg pains or knee pain. He should also not mind talking about her obesity. Of course, they are talking, and and in clinic level, probably you can have an assistant talking about it if you're busy treating the patients for fever and other, like common health issues, like um, if it's a ENT doctor dealing with ENT problems, or a clinician physician dealing with fevers and other medical conditions, diabetics. So, so we should do that. I think advanced technology is very, very important. We can use advanced technology in any form to bring the correction to the patients. Thank you.
Thank you so much, ma'am, again for answering this question. Dr. Sahai, can you hear us? We are audible to you now. Our team is trying to coordinate with sir. Like I think he is facing some issue. Like, ma'am, we have taken all the questions of the participant, ma'am. Ma'am, shall we conclude this session with all your permission for today's?
Yeah. Just add a few things. Nowadays, people are
Yes.
very intelligent. They Google, they go to Meta AI and read about lifestyles. I think we can even suggest those things to the patients at clinic level.
Thank you so much, ma'am, for adding some valuable points to this topic, ma'am. With this, ma'am, we have came to the end of the talk. I would like to thank Dr. Shai and Dr. Nanda, ma'am, for your valuable time. And the talk was incredibly cross talk between endocrinology topic and bariatric surgery has clearly demonstrated the patient outcomes from the collaborative and multidisciplinary approach, ma'am. With this, ma'am, we are closing for today, and we would like to see you in future also with different topic. And I would like to thanks all the participant who joined this session, ask question during this session, and make this session informative one. And thank you once again. Good night,
Yes,
take care, and we will back with another episode next week Thursday with the doctor's perspective. Thank you so much, Dr. Sai and Dr. Nana, ma'am. Thank you, ma'am.